Good morning, everyone. Yate Bene. For those of us here on Mountain Standard Time in Arizona, but also good afternoon for those in the afternoon time right now. Uh, as I said, it's just after 11 a.m. and we're going to get started momentarily. We are going to allow a bit more time for others to join, but we're really looking forward to the session we're going to have together today. All right. Hello again, everyone, and thank you for your patience. We're excited to welcome you to today's featured presentation, a part of the Center for Native American Cancer Health Equity's quarterly webinar series. Uh, we'll go ahead and get started now. My name is Jennifer Hudson, and I'll be your moderator today. I serve as a senior community program coordinator with C-NACHE and am a proud citizen of the Navajo Nation. I'd like to briefly share my plans to establish any kinship connections I might have on the call. I am of the Mountain Cove clan, born for the Blackstreet Wooded people. My maternal grandfathers are of the Towering House clan, and my paternal grandfathers of the Water's Edge clan. And this is how I identify myself as a Navajo woman. I am also joined today by my colleague, Chastity Begay, who will co-facilitate this session with me. So Chastity, I'll hand it over to you to provide a brief introduction.
Hey everyone, good afternoon. My name is Chastity Begay. I am a research coordinator for C-NACHE. I am also an enrolled member of Navajo Nation. And to establish any kinship, I am of the Coyote Pass clan, born for the Bitterwater clan. My maternal grandfather is of the Towering House clan, and my paternal grandfather is of the Bitterwater clan. So yeah, to any relations I have out there. I will be mainly moderating the chat and looking out for more of the technology side. So nice to see everyone.
Awesome. Thank you so much, Chastity. So in recognition of National Cancer Research Month, today's webinar is titled Advancing Cancer Research in AIAN Communities, a Personal and Professional Journey. We are honored to be joined by our featured speaker, Dr. Natalie Joe, a postdoctoral fellow with the Cancer Prevention Fellowship Program at the National Cancer Institute. She'll introduce herself more fully in just a few moments. I do have a quick note. Today's session will be recorded and made available on the NAU Share YouTube channel for those who wish to revisit the presentation. This webinar series is made possible through support from the American Cancer Society. So with that in mind, and before we begin, we'd like to take a moment to set our collective intention. We recognize that for many Native American and Indigenous communities, cancer is a culturally sensitive and sometimes spiritually prohibitive topic. Our goal at C-NACHE is to approach this subject with respect, cultural awareness, and care, honoring the deep spiritual traditions that guide many Indigenous models of health and wellness. At this time, we invite you to reflect quietly in your own way on your intentions for being here. You may use this moment for personal prayer, reflection, or setting a protective intention for yourself and others as we enter into this dialogue. So if we just want to take a brief minute or so to set some time to do that, we'll go ahead and just take about a minute now. Thank you for taking that moment to ground yourself. As we continue, we also want to acknowledge the land from which we host this session. On our screen is an image of our physical location at Northern Arizona University in Flagstaff, which is overlooking the San Francisco Peaks, known colonially by that name, but held sacred by 13 Native nations in the region. We honor this sacred mountain and share the following land acknowledgement from NAU. Northern Arizona University sits at the base of the San Francisco Peaks on homeland sacred to Native Americans throughout the region, and we honor their past, present, and future generations who have lived here for millennia and will forever call this place home. Now, before we turn things over to Dr. Joe, here is a brief overview of who we are at the Center for Native American Cancer Health Equity, or C-NACHE for short. Established in 2022 through a grant from the American Cancer Society, C-NACHE aims to reduce the unequal cancer burden of cancer among Native American communities. Our work focuses on three primary goals: improving cancer screening rates, increasing access to cancer care services, and raising awareness about environmental contaminants that contribute to cancer burden in Native communities. Through research, community engagement, and partnership, we strive to advance cancer health equity in Native communities. And you'll see there also just a QR code if you want to scan that, which will take you to our link tree to learn more about C-NACHE and its activities. So now that brings me to the purpose of our C-NACHE quarterly webinar series. Our target audience includes Native American college and university students, though all are welcome to join. This series seeks to spotlight the many forms of cancer research happening across Turtle Island, with a particular focus on the Four Corners region. When many of us hear cancer research, we often picture lab-based science, but in reality, cancer research spans many different disciplines: public health, environmental science, behavioral science, policy, and more. This series highlights the diversity of pathways available with the goal of inspiring the next generation of Native researchers and advocates. And with that, I'm now thrilled to turn it over to our featured speaker, Dr. Natalie Joe, who in her own personal and professional journey has experienced the different disciplines that go into cancer research. And we're so looking forward to the insight that she'll be able to share with you all today. So with that said, Dr. Joe, the floor is now turned over to you. I'll go ahead and stop sharing and allow you to bring up your screen as well.
Okay, can you see my screen? Okay.
Yes, looks good.
Okay, perfect. Well, thank you for the introduction, Jennifer. I really appreciate it. And I just will share a slide going over who I am, what I've done, so you can read in the background while I do my introduction. So, Yate, She Natalie Jo Yanisha, Majishkijni Inshwa, Haskanzoi Bashishchin, Kitachini Dashiche, Dokazitana Dashanella, Aquatego Estant Nishlin. So I am from the Coyote Pass Hemis clan, born for the Yucca Fruit Strung Out on a Line clan. My maternal grandfather's clan is the Red House clan, and then my paternal grandfather is the Many Goats clan. And I'm really excited to be here with everybody for this specific webinar. And as was mentioned, I'm going to go over my personal as well as professional journey. And so I want to share a little bit about that. May is National Cancer Research Month. So here are some photos of me in various laboratory settings. That in the bottom is me with my parents, my maternal grandmother, and my wife. They're touring the vivarium, which is where all of the mice are housed. And then to the right up, I'm in a biomedical lab labeling some tubes, as well as in the bottom in a chemistry laboratory. And if anyone's ever done these photos, they're a little awkward. I'm watching crystals crystallize. So, context, I think, is not as important when you're trying to look like you're doing science in a photo. And for today's talk, I have no conflicts of interest. As was mentioned, so I will really be talking very broadly about advancing cancer research in AI and communities, and that stands for American Indian and Alaska Native communities. I'm currently at the National Cancer Institute, so I just wanted to share a little bit about my career journey and how I got started within cancer research. It really began first and foremost with family and at the community level. So, for those unfamiliar, here's the Southwest area, and this is where Navajo Nation sits. And I grew up in the Northern Agency in Red Valley, Arizona, as well as in Farmington, New Mexico. And as I was growing up, my mom told me a lot of stories about her uncles who worked within the uranium mines. So, during the 1940s to 1980s, there was over 30 million tons of uranium ore that was extracted from the area. And a lot of that was done by our relatives and community members. So my mom would talk about how when her uncles came over, they would, wash their clothes that was covered with uranium dust, as well as hang out with family members. And so there was that secondary exposure that happened, and many suffered adverse health outcomes, including kidney disease as well as lung cancer. And so hearing these stories growing up, I really wanted to do something within cancer research. So in undergrad, I attended Fort Lewis College. And for 3.5 years, I worked in Dr. Amy Morris's laboratory, which is an inorganic chemistry synthesis lab, where we were making cancer treatments called anti-cancer prodrugs. Um, and they were modeled after similar already available chemotherapeutics, but with a more abundant and less expensive metal at the core. And I really enjoyed this research, learning how do you actually make new treatments. But at the end, I really wanted to know, okay, so we've made this new treatment. What's the next step after the chemistry lab? And I was told that now you need to determine, does it actually work? And so to test that, you look in the context of cancer cells in a dish, then you try in an in vivo model, so a living model like a mouse model. And that's really where I wanted to spend the next stage of my career. So I became a student within the cellular molecular medicine program at Johns Hopkins School of Medicine. And that was really just what I spent my education on, was learning cancer biology as well as that preclinical research. I joined Dr. Riggins' laboratory, where they were using an already FDA approved drug that classically treated parasitic infections, but they found that it was effective in treating brain cancer. So before I joined, there was already evidence to this effect, and they already saw within those cancer cells as well as in mouse models. And it was starting to progress to where it was going through clinical trials. So when I joined, I helped to see if that drug, mebendazole, could be used in thyroid cancer. And then my thesis work was really specific to breast cancer. But during that time, as clinical trials were going through, so phase one is really to test what are the toxicities associated with this drug. Like, can healthy individuals tolerate taking this? And then phase two is more of that kind of initial test with some people who have the disease of interest. So in this context, it's brain cancer. And then third phase three is a randomized clinical trial to really pit it up against the standard of care and see if it's actually effective as we think it is within these patients. And I really started to ask my mentor questions about who's being recruited for these clinical trials, how do they start to, decide which communities get access first. And it was really then that I started to realize I had moved far away from community, and that it would take a while for what I was working on to get back home to my family. So in that last year of my PhD, I started to work on a project with the Center for Indigenous Health. It's a breast cancer prevention project with two tribal communities in the Southwest, and one was Navajo, or is Navajo Nation. And I was helping prep the educational materials for breast cancer prevention, so trying to increase screening. And I really started to learn the broad scope of utility for public health research. So it was at this time that I applied for my current postdoctoral fellowship here at NCI. And as a part of the Cancer Prevention Fellowship, they funded my Master's of Public Health. So I attended Johns Hopkins Bloomberg School of Public Health, continued to do that work with the Center for Indigenous Health for my practicum hours, as well as concentrated in epidemiology and biostatistics. And really, this whole path trajectory allowed me to be able to get back to community while I'm working here on site at the National Cancer Institute. And as I'm kind of broadly speaking about community and the Indigenous population overall, I really wanted to ground us in who am I speaking about when I'm saying this. So take it from the United Nations definition. This encompasses individuals who are descendants of those who have inhabited a country or a geographical region at the time when people of a different culture or ethnic origins have arrived. And usually those new arrivals are kind of who we see as the dominant culture today. And they became the dominant culture through either conquest, occupation, settlement, or other means. So when we're thinking broadly, this really encompasses around 370 million people worldwide. So it is a big population that we're discussing. And there are certain criteria that actually make up the Indigenous community that the UN defines as well. So here are some of those specific criteria, including, distinct language, culture, and beliefs. For me, I really always focus on that first point, which is that self-identification as an individual and that you have acceptance as a community member, because I think there's sometimes confusion on the first point. And I always look to one of the Indigenous scholars that I look up to, who is Dr. Kim Tallbear. So she stated that, quote, "We construct belonging and citizenship in ways that do not consider these genetic ancestry tests. So it's not just a matter of what you claim, but it's a matter of who claims you." And again, really drawing that point back of that we as community members know who our members are as well. And so for my talk, I will be referring specifically to the Indigenous people of the Americas that currently reside within the boundaries of what we call the US. And some common terminology that you're going to hear throughout the talk are really based in the social constructs of race and ethnicity. So this includes non-Hispanic, which will be abbreviated NH, Hispanic H, American Indian, and Alaska Native, so AIAN is how I'll refer to the population moving forward. And here's some data from the most recent census from 2020, just to kind of give you an idea of where the federally recognized reservations as well as land trusts are located. So the green, blues, and some of the pinks you see on the East Coast are where those lands are, but all the tan areas doesn't mean that there are not Indigenous people who are living there. Again, I just want to highlight kind of the spread out area of the reservations as well as land trusts, so we all have a good idea of that. And so moving from here, this would be just general where the population is, and that really feeds into cancer surveillance work, which is a basis of what I work on. And the data really informs on where cancer health disparities or differences really are. So there's the collection of the specific data as well as the analyses. And for us to start to make any progress to address these health disparities, we really need accurate and high quality data, as well as those who are involved in the process really being good stewards of Indigenous data. And I kind of bolded and put an asterisk there because Indigenous data kind of is outside the realm of what we think of when we think of Western science data. So it encompasses Indigenous resources as well as our environments, the individual, and then collective, so the entire Indigenous nation as well. And so taking that and keeping that in mind as we move toward more of cancer surveillance data, I really wanted to highlight at two levels a couple of projects that I'm personally working on and then others that I'm working on in collaborations. So at the national level, as well as within individual tribal nation statistics. The data set that I'm working with in the surveillance research program here at NCI is SEER. So that stands for the Surveillance, Epidemiology, and End Results Program. I want to share a little bit of history associated with NCI. So NCI, really what we see it as today, was established through the National Cancer Act by President Nixon. And it was really through that effort that started SEER in 1973. And in 2023, we celebrated the 50th anniversary, and the entire purpose of SEER really is for that collection, storage, analyses, and dissemination of the cancer data for all of the populations within the US that is covered by SEER. And I say covered by SEER because when it initially started, there was about less than 10% of registries that were associated. And that includes tumor registries as well as hospital registries. And that's where we kind of get those cancer cases from. Whereas now, more recently in 2023, we're almost up to 50% of the population. So even though this covers a majority of the nation, it's not nationally representative, just to keep in mind. So with this specific data set, what I've been doing is trying to really get an understanding of how have we classically gotten cancer burden information for all of the AI-AN population, as well as what will be the impact of upcoming changes to how we kind of classify the AI-AN population. And that's really based on a couple of specific methodologies. The first is coming from the Office of Management and Budget, or OMB. They had 1977 guidelines of how we classify people in race as well as ethnicity. So that's how you kind of get initially AI-AN. But then there is some misclassification problems within the specific population. And so the bottom three methods are really what we use to try to best accommodate that. I'm not really going to go into detail in those, but I'd be happy to answer any questions in regards. I'll really focus on the top. But for restriction, we restrict specifically to non-Hispanic ethnicity. And this really is due to an increase in the Hispanic AI-AN population that we saw from the 2000 census to the 2010 census. And then we also only look specifically at counties designated by Indian Health Services as the Purchased Referred Care Delivery Areas, or PRISDA areas. In addition, for individuals that have been classified not AI-AN, we can bring those individuals back into our analyses through an IHS linkage. And IHS, you can receive healthcare only if you are a member of one of the federally recognized tribal nations. So again, that's how we can further find our population of interest. And so next, I really want to focus on that top point of that race and ethnicity classifications, because it was updated in 1997, and now that new classification is starting to be implemented. And so a lot of my work really focuses on what will be the impact of that. And I'm going to broadly go through how we classify kind of three fictitious individuals so you get a better idea of cancer rates. And just broadly speaking, for the numerator of that, those are individual cancer cases, and then just over the entire population of the denominator, so that our AI-AN people identified more at the registry level as having cancer, and then from census data of the entire AI-AN population. And this race classification really is more specific to the entire denominator of the population. So here I created three fictitious individuals. The first person has elected AI-AN alone, so they've only selected that race. The second person is biracial. They selected AI-AN and non-Hispanic white. And then the third individual is multiracial, so they selected non-Hispanic black, non-Hispanic white, and AI-AN. And more often than not, from recent data as well as more historical data, you probably have seen these cancer incidence rates in bridged race. And the way that this is created is they're taking the data of if you've selected one, biracial or multiracial, and then they make a bridged race factor back to those 1977 classifications. And this was really based on a National Health Information Survey where individuals that were biracial or multiracial were asked, if you had to choose one race that represented you, which would it be? And so that data made bridging factors that are used again to bridge people back. And so this is an oversimplification of that process, but these three individuals more likely than not would be in the AIAN population. And here in SEER, we use or in the surveillance research program, we use another classification called in combination, where we are really trying to attribute all of the information from people into every racial category that they identify as. So it's each race alone as well as in combination. So you see all three of the people here in AIAN alone and in combination because they all selected AIAN. Then you have non-Hispanic white alone and in combination, and that's the two individuals on the right. And then you have non-Hispanic Black alone and in combination. But at least this way you get at trying to attribute across what individual people have identified as. However, it will result in an over 100% right statistic because you're counting people more than once. And that update I was talking about from 1997 that's starting to be implemented is using this categorization. So it's a lone race and multiracial. And now the two individuals who did select AIAN will now be placed in that multiracial category. And this is what a majority of my work is looking at is what will be the impact. And the next slide, I wanted to show kind of a hypothesis of what this could be like. Again, this is more of a high level overview and not exactly based in what the data look like. And so with the new categorization, it could be resulting that a majority of the people that are biracial and multiracial will be counted in that large category instead of being an AIAN alone. And this is stemming from data from pediatric cancer, where we're seeing that a majority of our youth are identifying as biracial and multiracial, opposed to one race alone. So the way that I'm looking at this specific impact is using that 1997 race and ethnic standards with SEER data from 2020 and 2021, and taking the same population and data, but categorizing in all three of these. So bridge race, in combination, alone, and multiracial, to see how that really changes what the cancer incidence is for the US AIAN population. And that's kind of a broad overview of one example of national level statistics that I'm working on. And then now I'd like to go more into at one tribal nation level, so with Navajo Nation. And the work that I'm going to show is supported in part by C-NACHE as well as NACP, because a lot of members at NAU are a part of the Navajo Cancer Work Group, which I'm a part of. So this comes out of the Navajo Epidemiology Center, and that is one of the tribal epidemiology centers, so a tech that comes out of the CDC, so the Center for Disease Controls. And the work group that I'm part of is a huge collaboration, and it's been ongoing for over 2 decades. So it includes people who are members of the Navajo Nation government, different federal agencies, nonprofits, as well as academic and research institutions, state government officials, and cancer registries, among others. And so it really takes this large group of people not only to get access to the data, so having like a memorandum of understanding, as well as just ensuring that we're involving everybody who has a part in the Navajo people's cancer control like continuum. And one big project that comes out of this work group is cancer surveillance data. And so the Cancer Among the Navajo report, the third one, has been released. And so now there is data analyzed specific for this population from 1994 all the way up to 2018. With the most recent report, there has been the creation of a cancer data dashboard that's now live. So you can go onto the Navajo Epidemiology Center and kind of go through this and click data by data. So I just kind of wanted to highlight what's actually in this website. So first, you can look at Navajo cancer counts specifically. And to break this down, here you have year, but you're really going back and forth between the most recent report and then the previous. So you're looking at two reports. Then you can also split by gender. So where you're looking at male and female together, and then split male and then female. And again, you're just getting overall numerators, so all of the cancer counts within that year. And it is split down by what's the highest versus the lowest that's been counted. And then we actually also have rates to get an idea of where the population differences are. This is given in comparison to non-Hispanic white individuals that are in the same counties that were analyzed within Arizona and New Mexico. So this dashboard page, you see the first report and the second report. So it's in the lighter blue and then the darker blue. Then you can also flip between the different cancer sites as well, and then split by gender. There's also data on cancer staging. It's not really on like the T and M, so like stage 1, 2, 3, 4. It's more early and late. So what that means is for an early cancer diagnoses, the cancer is still within the primary organ that it was found, or it's still kind of localized in the area. So for instance, for female breast cancer, it may still be in the tissue, like the breast tissue, as well as maybe in a lymph node by your armpit. So that's still localized. Whereas late stage means that it's moved somewhere further. So it's metastasized to another area. So that might be in the bone or the brain. And you can, again, look specifically at which specific groups. So this is for non-Hispanic white individuals and for colorectal cancer. And there are 3 sites you can look at for this. Another data set we have is for death rates or mortality rates, and this is for the top 10 cancers. And again, you can look at the 2 reports as well as the gender. And then again, specifically looking at both populations of the Navajo people and non-Hispanic white individuals. So I think this is a really awesome tool that was created. And again, the audience are for community members or really just anybody who's involved in the cancer care for Navajo people. And the idea is that as reports continue to come out, that website will continually be updated. And so you can get the most accurate data. And also, we are currently working on getting published the most recent report in a peer-reviewed journal, as well as taking that data and using it to apply to a Navajo cancer control plan based on that surveillance data. So here are all 3 of the reports, which highlighted what cancers are high in incidence, so those new diagnoses, as well as what are kind of contributing to those mortality rates that we're seeing. And we're looking at that across the cancer care continuum. So that includes outreach, prevention, education, through diagnosis, treatment, and all the way to end of life care. And the portion that we're really trying to apply is the Navajo wellness model. So at that cancer care continuum with the data that we have, because taking all 3 of these things together will really give a roadmap for us to figure out, okay, how can we decrease burden for the Navajo people moving forward? And the plan that we're working on, all of the objectives will hopefully be achieved, or the goal is to set them for 2035. There are myself, as well as other members of the Navajo Cancer Work Group and Dr. Linda B. are working together. Some of the topics that I want to highlight that are in this cancer control plan are capacity building, so infrastructure and workforce, as well as data and access to care. Again, the audience, similar to the dashboard and kind of a lot of the work that the Navajo Cancer Work Group does, is just for anybody who is involved in the cancer prevention and control for our communities. So I hope during my talk, I was able to give a broad overview at the national level, as well as for one tribal community about cancer surveillance data, because the cancer surveillance data is really important for the AI-AN population. It shows really what's ongoing with the community's health at this time when you're collecting the data, and whether there is a disparity. So then you can start to plan for different interventions, and that shows where resources will be allocated. So your time and your money at the tribal nation level, as well as the government. And as you continue to collect that cancer surveillance data, you can see what the impact is of those interventions, of whether you're actually making a difference or if you need to shift where your priorities are. So that is really why I've been focusing specifically in this area for my postdoctoral fellowship. And I'd like to really thank everyone that I've been able to work with and collaborate with, especially my mentors, Doctors Kathy Cronin and Shobha Srinivasan, as well as all of the members of the Navajo Cancer Work Group, people at my fellowship. And yeah, I really appreciate you spending the time with me to hear me talk about my work. So thank you, everyone, and I'd be happy to take any questions.
Woo! Awesome. Awesome job, Natalie. Thank you so much for sharing all your experiences and insights. Now that is what I call cancer research right there. Love to hear all about it. We'll go ahead and transition now then to our Q&A session with Dr. Joe. We do especially encourage our students to participate in this and ask the first round of questions. And then we'll go ahead and open it up to everyone else on the call. But for now, I'll just turn it over if anyone's got a burning question. And you can do this by coming off mute, or you can drop it in the chat and we can read it for you, whatever works best.
I have a general question, if possible.
Yeah, go ahead, Michael.
This is hi, Dr. Hi, Dr. Joe. How are you doing today? Thanks for the presentation.
Yeah, thank you. I appreciate you joining.
Thanks. I guess my general question is in regards to the stratification by race and ethnicity. And I know that for the larger national data set, I'm just curious to know if you foresee any sort of complications with the current administration in regards to collecting new data moving forward, and with that stratification of classification for race and ethnicity there, especially as regards to cancer research and such.
Yeah, that's a great question, a really big question that I think goes above my pay grade, but I can definitely foresee some changes. However, I'm, very hopeful, since there's been a consistent emphasis of upholding the federal obligation for the AI-AN populations and really prioritizing the specific work of focusing on health differences. But I'm hoping that that stays moving forward, because my work is still pushing forward. But yeah, I really can't predict what will happen in the future. But thanks for asking the question.
Great question, Michael. And Michael is actually one of our current NASWAC cohort members who helps inform this webinar series. So really glad to see that. I know we have others on the call, other members. Really excited to see you all here today. Oh, speaking of, Mariah, I'll go ahead and turn it over to you.
Hi, Natalie, Joe. Thank you again with your presentation. I too am currently going to school at Fort Lewis College, so I know the professor you're talking about. I do have a question about how you guys gather your information on like breast cancer screens, and like how do you get your reports? Is it mainly on the reservation, the Navajo Nation reservation, or is it in the surrounding areas?
Yeah,
like
that's
Farmington.
a great question. So a majority of the data that we have for the specific reports are coming from the registry data. So that is pulling on Navajo Nation side, like actually on the Navajo Nation, depending on data that IHS has, as well as some from the neighboring regions. But again, a majority of it is already what's being collected. But if you wanted more granular data about, okay, where's somebody diagnosed and then where are they getting treatment and all of that data, we're still trying to figure out all of the nuances. I know that that is really a priority for IHS to kind of figure out that geospatial mapping. So it really is a majority of what's already available for the registries and then what IHS has.
All right, thank you so much.
Yeah.
Awesome. Thank you so much for asking that question, Mariah. Oh, I have another hand raised. Michael?
Yeah, thank you. My question is just in regards to data linkages. I think you had mentioned briefly, or I just kind of heard the word linkage, I think, in regards to linking some of the data and using IHS as kind of like a source hub for getting that information. And I'm just curious to know if you received any sort of, or what type of challenges you maybe had experience trying to do that data linkage. And I know it's something that we have a bit of a trouble sometimes with, because I currently actually work at the Albuquerque Tech in Albuquerque.
Okay.
So we work pretty closely with Navajo Nation Tech on some projects, but I'm just curious to know, because where we're at located in Albuquerque, right, and we work with the different tribes in New Mexico, including a lot of the Pueblo tribes, right, there's a lot of, how to say, just some difficulties working with specific IHS facility sites in regards to, of course, sharing of data, data sharing agreements, especially since we're working with multiple tribes and not just one singular entity like Navajo Nation, right? I'm just curious to know what type of linkages or what type of, you know, as far as just maybe just learning a little bit more about the process for data linkage with IHS facilities, specifically on the Navajo Nation, right? Because we have maybe multiple sites or multiple IHS sites. Was there any difficulties you had there with getting that data available to you?
Yes, that is an excellent question, because to your point, it is a very complicated as well as, arduous journey to do these different linkages. And this is really stemming out of that over 2 decades of work that this Navajo Cancer Group has come together. And there's been work to make that memorandum of understanding with all of the different tumor registries, as well as IHS. And the IHS linkage that the data we're using is actually coming from CDC, so the National Center of Health Statistics, because IHS will link annually the cancer incidence data. And so that's readily available. Whereas the mortality data, they're consistently updating at CDC. And I really would point to Melissa Jim and Stephanie Melkonian's work. So that's why you see so many people involved in that Navajo Cancer Work Group, just because it really does take different federal agencies and a lot of behind the scenes work to make that happen. But that linkage I'm referring to is not to specific sites and for specific people. It's really already happening at a national level. Like it's already a standard of operation for that data.
That makes sense, Dr. Joe. Thank you so much. I appreciate answering my question.
Yeah, of course. And good luck on all your projects.
Got some powerful minds on the call. Really exciting to hear all of that. I don't know if we have another question from any of our students on the call. If not, I do have a question from one of our community advisory board members, actually, Joyce Tovar. And she asks, do you think tribes with small populations will benefit in having a similar dashboard?
Yeah, that is a great question. I really am of the mindset that, every tribal nation or indigenous community that wants their data should have access, right? Indigenous data sovereignty. So then they can make the community decision of what they want to prioritize, because even though it takes the data to drive the research forward, community already knows what's happening, right? You know what's happening within your family, what is needs to be prioritized, and you just always need that data to back it up. So I would say that I think it would be a benefit for any tribal nation that wants to make that progress forward. So that would be, I think, the ideal, especially since this is coming from the Navajo Epidemiology Center. And the capacity, though, for each tribal nation to do it, I think, is where that kind of needs to start as well.
Awesome. Thank you so much for that response, Natalie. I do have another question in the chat from one of our NASWAC students, Jessica, who asks, is there any other types of dissemination to the community alongside the cancer report?
Yes, that's a great point. I really do think it takes a lot of, effort to make sure the community is aware of the report, and then it's in a format for everyone to really understand what's ongoing. So there has been work from the tribal epicenter, the Navajo tribal epicenter. I believe that through funding from the NACP as well as C-NACHE, these reports were printed and then taken to various community events to hand out to the public, as well as there's been different webinars. So Del Yazzie from the Navajo Epidemiology Center gave a presentation. And again, we're all trying to disseminate through multiple different channels so people know that it's out there. But that's also why I was trying to highlight again today, just in case anyone's not aware that this dashboard and that these reports are out there.
Yeah, definitely, Natalie. I believe that went live last summer. Was it the dashboard?
Yeah, the dashboard, I believe it was at the end of fall, like, because they did the launch event last
Right,
fall.
yeah. So
Yeah.
it's been live for almost a year now, but yeah, still trying to bring attention and awareness to it, and definitely getting our Navajo community members to explore it a little bit, kind of see what that looks like, that sort of thing.
Yes, exactly.
All right. Any other general questions from the broader audience or again from our students? We have just about 10 minutes left, but we have spoke with Dr. Joe, and she has graciously offered to stay on an additional 5 to 10 minutes after we conclude the webinar in case there's any more informal one-on-one questions our attendees would like to have. Okay, I don't hear any coming. Oh, the chat just went off. Let me see. Oh, Nikki Jurgens just says, thank you so much for sharing your work and story. Thank you for attending today, Nikki.
Yeah, thank you.
All right, if there's not another question, I'll just ask Dr. Joe if you have any final reflections or parting words for our attendees today.
Yeah, I mean, I think one portion to highlight is, even though in the beginning when I talked about my journey, that the way I framed it was very straightforward and like I knew what I was doing in every different step. But I would say there's a lot of times when you're questioning which direction, as well as different opportunities that arise. And so when I started in undergrad, I was really thinking I wanted to go the medical path and being an oncologist. So I was doing a lot of shadowing in the hospital, so at San Juan Regional, and I realized that it took a lot of, emotional stamina, and that I couldn't foresee myself consistently doing that. And so as I was also involved in research, I realized I really like this. And so I debated, do I want to stay within chemistry research? So I applied for a summer research opportunity within a cancer immunology lab, and I really enjoyed that. Then through that work and the work at Fort Lewis, I was able to attend a conference, and that conference paid for my first ever flight. So I went to Los Angeles to present at the SOCNIS conference, the Society for the Advancement of Chicanos and Native Americans in Science. and they have a huge expo hall. And so I went through and talked to people, and I literally collected all of the brochures for PhD programs and I applied to them. And then out of the 10 places I applied, I immediately got 2 swift rejections. And then thankfully the rest, I got interviews, I practiced, and really, like, the way my journey happened, I really couldn't have predicted very, very early on. So again, just consistently follow what you would like to try and what you would like to learn. Say yes to different opportunities. It's going to be tough. You'll have people who are more of those naysayers, but just continue to, again, lean on your support system. So that was always my family, my spouse, and feedback from other colleagues. But yeah, it really, it takes a lot to kind of go through the entire science journey. And I see Michael's hand up, so I can take another question.
Sure, yeah. No, thank you for sharing that. That's definitely something that I can resonate with. I think kind of going through that personal journey. It's something I think I'm still currently going through right now. Now that I'm actually back in school getting my second master's in statistics. So trying to just find that kind of niche of that professional niche of where I think I can kind of be most of benefit to the community. So just appreciate you sharing that. And I guess with that kind of question, or with that being said, the kind of question I want to ask is just basically with the current state of cancer research or where it's currently at, and what you're kind of hearing and seeing in the community and what you're learning through your your experiences now. I'm just curious to know, like, what are some things that you think you, I guess, in what areas of research for cancer research right now and the nomination do you foresee they're a lacking in, I guess, or like, is it what space of knowledge do you think there's a lack of? And I guess where somebody like myself who's wanting to contribute some sort of additional knowledge base, right? Where do you think we could step in to provide that extra bit of just to kind of fill in that space there? I know for a fact one thing I'm doing right now is just learning the use of AI ML technology,
Mm-hmm.
especially how it goes into like predictive variables and things like that, and especially how it can go into public health surveillance. I know for cancer surveillance, it could be very beneficial, I think, if you could utilize some of that particular technology, just for example. But just curious to know if there's anything you think that we are lacking in that you think up and coming individuals, public health individuals, research can kind of fill in the blanks.
Yeah, this is a great question. Something that, as you shared, I consistently reflect on is where now in my next career stage of where it makes sense to go and would be most impactful, and talking with mentors, community members, and as well as collaborators. We need everybody. So if you're interested in AI and machine learning and modeling, we need more people there. We need people who want to work directly just with community. We need people who either want to nerd out about the data like I do right now. And so I feel like you really just continue to learn and follow and build your specific skill set of what you're interested in. With the work that you're doing is important because you're bringing that Indigenous perspective, right? You're coming from community. And I think there's not enough Indigenous researchers to ensure that good science is being done and we're all being, in good relation with one another. So I feel like we'll each find our different space. But as you saw in my journey, I went from inorganic chemistry all the way through back to public health. So you'll pick up a lot of skill sets on the way, because that's also what I've learned throughout, my journey, is that you even look at Dr. Priscilla Sanderson or Jenny Ingram, and they're all doing 50 to 100 different projects, right? And they've just learned the skill set that they need because that's what community needs from them at that time. So I feel like even what I'm doing now will continue to evolve. So as long as you're keeping your, ears open to what community needs and what you've trained to do, I feel like you'll be on a good path.
Thank you, Dr. Joe. No, that's really helpful. Thank you. I think it's just very hard nowadays because there are just so many things that you can do. And with the amount of technology, the amount of methods and things like that you can basically consume, right? I mean, there's like so many different coding languages you can learn. There's so many different things you can do. And it's just like, I think for myself, it's a little bit overwhelming feeling like I have to learn every single thing in order to feel like I can contribute in any sort of beneficial way. And so I think really just kind of, like you said, just honing in on things that I think that we feel passionate about, and then just kind of just becoming experts within maybe that one particular thing that we have passion for, and just moving forward with that, and then hopefully it can be applied in some sort of way to helping the general population, I think. So, but I appreciate it. Thank you.
Yeah, absolutely. And a lot of the training, I feel like even since I went to school since I was 3 and then stayed in school till 25 years plus after that. And all that school really taught me was how to think and problem solve and troubleshoot. So I think as long as you're working through that kind of scientific process over and over, like that's the skill set you're going to take to every different project, regardless of the field.
Wow. Thank you all for that. Dr. Joe, for your kind words and encouragement, and Michael for your question to prompt such words. I'm sure everyone was thinking similarly about how we can all take our efforts, especially now, and contribute to cancer health equity, especially when it doesn't seem like that's all that possible right now. But as we look around the room, we can realize that there's a lot of different strengths and unique strengths that we each bring to this overall effort. So really powerful stuff, and I'm really glad we had the space to welcome all of that in. Just wanted to thank you all for that. And again, thank you again for attending and being such an active audience, and for Dr. Joe for taking some time to meet with us this afternoon. We really appreciate your insights and experiences. So before we log off, we want to take some time to get any feedback from you through this evaluation survey. That can be done through the link in the chat, or you can scan this QR code with any device that has a camera and can take you to the internet. All of your feedback really enhances what this webinar series looks like, what speakers we should reach out to, what topics we should cover, and all of that. So we have great speakers like Dr. Joe herself. So again, I just want to thank you for being here. We hope to see you at our next webinar. We have 2 more for this year, so stay tuned on our socials, our website, our newsletter to hear about our next one. So for now, I'll just close it out, but I hope you all have a good rest of your day. Thank you.